Yeah, so we can start.
Okay, hello everybody. Welcome to the presentation. I'm so happy to be here. Thank you for the invitation, my gracious hosts. It's great to share this work with you. So I will be talking about ACT for psychosis, focused more in acute care settings. So that would mean like inpatient hospital settings, things of that nature. So my name is Brandon Gaudiano. I am a professor at Brown University in the United States. I also work as a clinical psychologist in Butler Hospital, which is in Providence, Rhode Island, which is a psychiatric hospital. So a lot of my work deals with patients who are in a day hospital, inpatient, or are transitioning out of those environments. So just very briefly, I'll sort of put up my disclosures of funding and things like that so that that's transparent. And then in terms of what we're going to cover today, we don't have a huge amount of time. So I'm going to try to do this in about 45 minutes, and then we'll have some time for questions and answers and participation. So please hold your questions to the end if you can. So I will start by just giving you a very brief overview of the research for ACT in acute care settings, talk a little bit about then how we would adapt ACT specifically for patients with psychosis, and talk about some clinical examples. So I'm going to assume that the audience has a um, some basic knowledge, hopefully, of ACT, most of you. There will be some chance for refresher or just reorientation, but I'm going to sort of not just go over the basics, kind of talk about more the application. And like I said, this could be relatively brief. So, one good source is a chapter in this book that recently came out that my colleague Martin Tierberg, who is from Sweden and does ACT for inpatient work, we wrote this chapter, and it explains a lot more in detail of some of the stuff I'm going to go over. So if you're interested in that, please let me know. I can make that available to the audience. So I think one nice way to kind of orient ourselves to ACT treatment processes is this be present, open up, and do what matters model. I think it kind of simplifies ACT and is kind of a good basis to start with thinking about how we can apply these things to psychosis. But just as a brief refresher, the idea is the first step would be to be present. That would encompass things like mindfulness and sense of self. The next step would be, once we're present and aware, we can be more open, accepting, and willing for whatever thoughts and feelings come up. That's a very helpful next step, and that sort of touches on diffusion, cognitive diffusion, and acceptance processes. And then we want to put these things in the service of doing what matters to us in terms of being able to identify and commit to our values and improve functioning. So, if we're doing all those things, that's going to foster psychological flexibility, which is adaptive and allows us to be more effective in achieving our valued goals. So, when we think of third wave therapies for psychosis, they're taking those principles that I just outlined, and they're thinking about how they would apply for people who have various experiences of psychosis, what we would call psychosis. That would mean people who have hallucinations or delusions, negative symptoms of psychosis, could be episodic, could be chronic, sort of thinking about how that would apply. And just to acknowledge that ACT is not the only third wave approach that has been studied or delivered for people with psychosis. Here's sort of a summary of some of the more major third wave therapies that have all, to a certain degree, looked at how to adapt these things for psychosis. So, metacognitive therapy, something called person-based cognitive therapy for distressing psychosis from Paul Chadwick. We have various types of meditation, mindfulness focused groups for people with psychosis, compassion focused therapy, and of course, mindfulness based cognitive therapy. And so, just to acknowledge that there are a number of different third wave approaches that have been found to be at least somewhat useful for this population. And that sort of led me a few years ago to edit a book on this topic where I tried to sort of do a survey or cover of these various approaches that focus on acceptance and mindfulness. And basically, sort of my conclusion was there were about four key things that these third wave therapies all embodied to a certain extent. And you'll see that very prominently in ACT. But they're about how to look at mindfulness, acceptance, self-compassion, and values, and how to apply that to this clinical population in a way that is going to be most helpful. And it does require some adaptation from the standard approaches to these types of processes in other groups that we might be working with. And I'll get into that in a minute as to kind of what the modifications are. So let's talk a little bit about ACT for psychosis, particularly in the inpatient setting and kind of what we know about it. What I've always done as an approach to trying to do ACT in an acute care setting is to think about how to really boil down ACT into more sort of more its core components, because generally in inpatient settings, they're time limited. At least the settings I work in, especially in the US, we have a very quick length of stay, very fast length of stay. It's only about 5 days. I know in other countries it can be several weeks, but it's still often a relatively short amount of time. So when you think about that, it's not your typical outpatient week by week, several month or longer therapy. So you have to kind of think of how to focus on the things that are most important. And generally, when we look at the inpatient space with applying ACT, we can think of some basic things that we're going to focus on for how do we adapt ACT for this population. So first is we want to identify where avoidance is getting in the way for that individual. They're often in some kind of crisis that has happened recently. They might had a relapse, they might have a clinical deterioration, they might have more acute symptoms. And so what we want to do is explore how acceptance can be an alternative to avoidance when it comes to dealing with whatever psychological distress that they're currently or recently experiencing. Next is if they have any active psychotic symptoms, and I'm talking more about the positive symptoms of things like I would say hallucinations or delusions. What we want to do is kind of take a mindful practice a mindful stance toward this. So to help people to not necessarily push them away or ignore them, but not also to struggle or be preoccupied with them. Instead, to kind of acknowledge them when they're there, but to be less judgmental and less reflexively trying to fight or struggle with them or suppress them, to take a more mindful stance. And so practicing that with psychotic symptoms can be helpful to keep them from interfering as much with their day-to-day life. And then instead, what we want to really do is identify personal values and consistent goals that they can move forward with their life so that they can improve their functioning, their quality of life, even starting in an inpatient setting. We want to apply those things right away. So if you'll notice here, there's really no attempt to focus a lot on changing any particular type of belief content or delusion, or to convince them that hallucinations are real or false. It's really about changing the way that they might relate or interact with these experiences so that hopefully these strategies that we're talking about here will help that to be less impactful negatively on their life. So the first study I did to kind of test out that model is we conducted in Philadelphia, Pennsylvania, in an urban city hospital, and patients were randomized with various psychotic symptoms, various diagnoses, to either treatment as usual during the hospital or treatment as usual that included individual ACT sessions. And on average, we delivered about 3 individual sessions over 1 week. So very brief treatment. So not a lot of treatment at all. And we looked at from admission to discharge, we looked at things like how much their symptom severity changes, how much their perceived disability changed, how they rated their hallucinations in terms of frequency, the distress associated with them, believability. And then after they were discharged from the hospital, we looked out for up to 4 months and to see if they were rehospitalized during that time. So some of the highlights I would note is that we found that ACT seemed to be particularly helpful for not decreasing the severity of hallucinations or delusions, but to actually be more impactful on the distress people had about them when they were there. So it tended to decrease distress, less reactivity. Again, this is consistent with what we were focusing on in the treatment. Also, there was less interference or impairment that they rated based on whatever psychotic symptoms that they might have been experiencing. So again, compared to the treatment as usual group, there was an improvement and a decrease in disability associated with their illness. We also found that when we looked at sort of large or clinically significant changes in their symptoms, that it was particularly not their psychotic symptoms that changed differentially. It was more their mood symptoms. So again, going to this idea that associated distress and impairment was really what ACT was most effective at reducing or helping the people to get some benefit from. And in particular, what we found is that even though, again, we didn't see any differences in psychotic symptom with ACT, what we see here is what we call a survival curve. And basically what it is, it's the time until they were rehospitalized after they were discharged from the hospital, up to 4 months. And the steeper the line, the faster they were rehospitalized. So as you can see, their TAU means treatment as usual. And so compared to the people who got ACT in the hospital, those who got treatment as usual, they actually had a faster rate of rehospitalization. So it seemed like what ACT also might be helpful for is helping people to function better when they leave the hospital. Another thing I might note is we found that there was one of the mechanisms of action of how maybe ACT was working is it seemed to decrease the believability of psychotic symptoms. So again, maybe taking this more mindful stance, help people to separate more and to observe them and not be as entangled in their psychotic symptoms. And so it reduced believability of hallucinations, and that seemed to produce decreases in their distress and decreases in their rehospitalization rate. So we followed up this project, and the new project that we did to study this was called Project Reach. And the things that were a little bit different about this is this was more focused on effectiveness and implementation of ACT in a real-world inpatient setting. So this time, instead of using research therapists, we trained hospital staff on the inpatient unit to deliver the treatment. And we also had a slightly different amount of treatment. So we had our individual therapy several times, but we also added an ACT-consistent group that was offered on the unit. And then after discharge in the first month, we also reached out to people by phone to check in to kind of further support their skills in a very brief way, basically about 15 to 20-minute conversations just to check in with them to reinforce some of the skills that they received. And then for our comparison condition in this randomized controlled trial, we actually used a supportive therapy condition. So the people who didn't receive ACT instead got the same types of elements that we're seeing here, but was a non-ACT supportive therapy to try to control for some of the expectancies and other factors. And then again, we also looked at their symptoms and their functioning and 4-month follow-up rehospitalization rates. And that's pretty much sort of similar to what I'm saying here. So we called our comparison condition time and attention match control and our ACT condition. And then everybody also received treatment as usual in the study. But they basically got the same amount of treatment. It was just either ACT or a supportive therapy. And what we found is that even though they were satisfied in general with the treatments that we provided, they actually had significantly greater satisfaction with ACT compared to the supportive therapy. So it seemed like ACT was acceptable, was feasible, but they actually liked it a little bit more than the supportive therapy. But there was no difference in the perceived credibility of both treatments. Both treatments were rated as about equally credible. And again, just like we saw in the previous study, overall, we saw psychiatric symptoms go down over the course of hospital treatment and then through follow-up, and there were no real differences between the groups. And and we use the brief psychiatric rating scale as a measure for this. But basically, we saw similar improvement in terms of severity of function of symptoms, including psychotic symptoms. But once again, as you saw in that previous graph, this is a new graph, but it looks very similar. We actually found again that those who received the supportive therapy condition and not ACT actually had a faster rate of rehospitalization after they left the hospital compared to the ACT group, which is that top line, which stayed out of the hospital longer. So again, even though ACT is not necessarily reducing symptoms at a faster rate, it seems to be improving functioning or doing something to help people to be able to move forward and speed up their recovery relative to the other group. And I would just note that these are just two studies that I've conducted, but there are a number of other studies. These are several meta-analyses that have been conducted of various inpatient and outpatient programs of ACT for psychosis. And basically, you'll see that overall they show effects on positive symptoms, negative symptoms, reducing rehospitalization rate, improving depression, improving, and again, working through mechanisms similar to increasing acceptance that we would expect as part of an ACT treatment. And so, we do now see sometimes ACT for psychosis appearing in treatment guidelines and empirically supported therapy lists. So for the example, the American Psychological Association lists ACT for psychosis and as an empirically supported treatment. And so does the Australian Psychological Association designate it as such. And so as more studies come up and as we have these meta-analyses, we see ACT getting more highlighted in terms of being a treatment option in addition to traditional cognitive behavioral therapy for psychosis. Okay, so that was just a very brief kind of orientation to some of the research that supports ACT for acute care settings. And so now let's talk a little bit more about what it would actually look like. And I'm going to start a little bit by describing a case to kind of give some context to some of the processes we're going to talk about applying. So this is a patient, Mary, who was hospitalized, and at the time she was a 65-year-old white widowed retired school teacher. And of course, I'm obscuring details so as not to to protect her confidentiality, obviously. So just understand that before I get into the details. But in general, this case of Mary, she had a recent hospitalization for paranoid thinking. She had auditory hallucinations, and she also had a significant amount of depression and suicidal ideation, which is why she came to the hospital. And she had been experiencing episodes of depression and paranoia since her 20s, and these were more episodic. And so she would have these episodes, and then she would sometimes be hospitalized for it. And when we look at before the hospitalization, we identified that she had some financial stressors given in her retirement. Her husband had passed away not too long ago, and she had some strained family relations. And she was also receiving, because she had depression and psychotic symptoms, an antidepressant and an antipsychotic medication, which she had some positive responses to initially. And so we think about, Mary's case, we could, kind of speculate here that the stressors and the lack of social support that she was experiencing recently led to an increased withdrawal and an increase in her rumination that she was having. This started increasing her depression and anxiety. The more that her depression and anxiety increased, the more she became isolated, withdrawn, and more preoccupied by these internal experiences, maybe avoiding or struggling with them. This actually then deepened her depression, and actually then she started experiencing more the positive psychotic symptoms of delusions in terms of paranoia and also auditory hallucinations. And again, this vicious cycle is really kind of driven by an experiential avoidance type process we saw. So when we think about, how the different 6 core processes might apply to Mary, that's what we're going to maybe spend a little bit of time in these next few slides, just sort of looking at some ideas for how we might address some of these core processes, whether it's cognitive diffusion, which means sort of being able to recognize and step back from our internal experiences and recognize thoughts as thoughts, whether it's acceptance, which is really talking about our willingness to make room for uncomfortable experiences without trying to change them. An idea like self of context, being able to shift perspective and look at our thoughts more than being our thoughts, to be present in the moment, to be non-judgmentally aware, which we of our ongoing experiences, which we sort of define in a mindful way. The person's values and sort of what drives them in terms of giving their life purpose and meaning. And then, how do their actions or their behaviors align with that or not in terms of their committed action. And again, another way that sort of just to refer back to that triangle in the beginning of the presentation is we can kind of group these processes into this open, aware, and active model to kind of simplify things. So again, we can think about these things in a more succinct way, especially when we're doing briefer therapy. We might want to think about it more instead of those 6 separate processes. We want to think about it as, okay, how can we help somebody to be more present, to open up to that experience, and then to pursue their life in a way that they value. And so again, I think one of the things that we find that it's helpful for patients like Mary is to first start a little bit with understanding, what's going on in their life recently, what led up to the hospitalization. And one of the things that's really helpful here is to orient the patient by talking about how some of those things might relate to this problem of avoidance, right? So ACT is really focused on this idea that often the overuse of avoidance in inflexible ways to escape internal experiences, that experiential avoidance, that really is more the problem, even though our minds often tell us that that's a solution or that's a way out. It just becomes kind of a vicious cycle. So it's really helpful to help to explore with the patient with psychosis how avoidance might be coming into play and making things worse in terms of whatever symptoms or distress that they're experiencing. So how do they deal with voices if they have them? Do they tend to try to ignore the voice? Do they fight with the voice and try to struggle with it, argue back? Do they try to block it out? All of these things are different forms of avoidance because we're trying to change something internally. We're trying to make it go away ultimately. And often if you kind of can interview a person and kind of walk them through that experience, often what they'll be able to identify is that it actually produces more, not less, of the problem over time, that the voices might temporarily go down, but then they want to come back and be louder or stronger or more disruptive. And so, one of the things that we use, of course, in ACT are stories and metaphors, cartoons, illustrations, videos, really anything that can help us to communicate these concepts in more approachable and understandable ways. And that's particularly helpful for somebody who is sort of in an acutely distressed situation where, they might not be as cognitively aware and open as they are at other times in their life. So one of the things that I find helpful for kind of illustrating, and this was helpful with Mary, was this idea of the beach ball metaphor, if you're familiar with this. So this is like when you're describing to a person avoiding thoughts or avoiding these internal experiences is like trying to keep a beach ball under the water and it keeps popping back up at you, right? So often people, you could use that if they have sort of problematic or derogatory voices. How much is that like they have this beach ball and they're trying to push it under the water so that they don't see it, so that it doesn't affect them. But of course, you can explore that when they push it under the water, sure, they can do that while they keep their hands pushing it under the water. But then what if they want to do something else with their hands, right? They're restricted. Or what if they forget and then they take their hands off and the beach ball comes back up, right? So it's really that sense of how avoidance is a problem, and then how we might look at a way to be more accepting of those things. So can we let the beach ball kind of float around on the surface, let the wind carry it where it may be. Sometimes it might come closer to us, sometimes it might get farther away. And we can apply that to concepts like voices that might come and go during the course of their life. Another thing that can be helpful for people that I found is sort of this idea of the two monitor metaphor. I've used this with patients like Mary, and this is the idea that kind of you don't necessarily always have to change the negative thoughts that your mind is giving you. Sometimes it's just the way you interact with them that actually makes a big difference. And so this is sort of the example, if you're familiar with it, of if you stare at something like a words on the screen that you don't like and you do it very close up to the monitor versus farther away, how that changes your perspective, how you don't, if you step back from it and you can see more in your field of view, that you're actually going to find that a less distressing and you're going to have more options. And again, if we're, it's a little hard to demonstrate virtually, but this would be kind of the idea, right? Like which version of that do you prefer, right? Do you prefer it when it's here, or do you prefer it when it's here? It's the same. It's the exact same thing, right? So this can be a great illustration to help people really, gain that sense of agency where, yeah, I don't actually have to make that go away. I can actually change the things I can control about the situation and make it more acceptable to me. Again, another very common and I think very helpful thing. I have a lot of patients with psychosis, and they really make this exercise or this metaphor their own, which is tug of war with a monster, right? Imagine you're, sort of in this life or death tug of war battle with a monster, and they're trying to pull you into the abyss, and you're trying to pull them into the abyss, but they never really cooperate and go fully into the abyss. And exploring with the patient, well, what would it be like to try something else? If you're caught and you're always struggling with that monster, you know what I mean? Is that something you want to continue to do, or what would it look like to do something different? And obviously, one option would be to not play that game anymore with the monster, to choose to step away from that game. Now, again, the implications of that are very important to explore with the patient. Is that doesn't mean that these things you don't like are going to go away. Doesn't mean they're going to shut up or be quiet or not try to taunt you or not try to get you back into that game. And in fact, you are going to find that you're going to get back into that game. So you are going to find yourself sometimes having confusing thoughts and getting caught up with those and maybe taking them too far and getting into the trouble, right? With delusions that a person might be experiencing. Or you might find that those voices are getting to you and upsetting you, and you want to get them to go away. So you start arguing with them again. But the idea here is that you can make that choice to drop that rope at any given time. And even if you pick it back up, you can drop it again. So again, this is something that we can do in session and go from session to session and say, okay, where are you at right now? Do you feel like you're struggling, that you're playing tug of war with your monster right now? Are you willing to put down the rope? And can we engage in the session in a way that might be helpful? Could we focus our attention on something else that actually, is more productive for you, let's say? Another thing that I like to use for patients who have acute symptoms is to liken their hallucinations that might be popping up in session like we would treat a radio on in the background, right? So if the person, I would want the person to acknowledge when they might be having a visual hallucination, whether they're having an auditory hallucination, and to bring that into the session and to acknowledge it for us to kind of make room for that, okay? Not to try to necessarily make it go away, but to figure out, well, how are we going to interact with this thing right now and still stay on task? So, I'll talk to them about, well, what do you want to do here? Do we want to stop the session? Do you want to go back to your room? Or would you want to continue the session? And if we do, how would you want to continue the session with this voice? What can we do with it? Well, maybe it's kind of like it's not what I'm experiencing, but what if we turned on a radio? What if we turned on music? What if we put something in the background that's going to kind of get in the way of what we're talking about? I wouldn't prefer that. I generally prefer to have the counseling sessions without background interference. But I would maybe be able to do that. I could explore what it would be like to do that with background noise. So I would then physically bring in a radio, or you could just use your phone. These days we have great technology. Put something on the background and illustrate and work with the patient to teach them how to stay in a situation and to make more room for whatever these things are that they don't like, instead of trying to feel like, oh, wait a second, I got to turn off the radio before I can have the session. And these are something that we can employ then for homework. We might say, well, when you're in group therapy, and you get this experience, how can you treat it just like the radio? And how can you stay with group therapy if you want to, instead of going back to your room? So again, these are things where we want to bring these things. We want them to be experiential. We want to work with them. We don't want to avoid psychotic experiences, but we don't want to struggle with them or fight with them. We want to find a more neutral, non-judgmental, mindful way to handle them. Again, another great metaphor that I often use, to relate to psychosis is this chessboard metaphor. Patients can find this very helpful because I usually bring a chessboard or checkers board, and then we can name the different pieces, and of the parts that they like or they don't like of themselves, right? Like they might be traumatic experiences, they might be voices, they might be negative thoughts, they might be any number of distressing things that they're experiencing. They might have physical types of pain and things like that are bothering them. So we can have these different pieces represented for those different experiences. And then the idea here, right, is that our thoughts are like pieces on the chessboard that are constantly in battle, fighting each other. They're always in the game. No one ever really wins. As soon as they're done, you just reset the chessboard and you do the game all over again, right? So there's somewhat of a feudal nature. If you engage at the level of the pieces your whole life, you're just going to constantly be in a battle, right? But we can also acknowledge that there's the chessboard,
I've
which
never heard of
also is part of the game. And sometimes it's actually good to feel like, how can I be more the chessboard than the chess pieces today? How can I be more an observer of the game versus the person who's kind of at the level of pieces fighting in the game? And again, just physicalizing it in that way by doing that can help people to realize that, well, these things on my board today, they're not the things that are always going to be on my board. They're going to
that.
change, and I'm more than the pieces on the board. And so I think that can be a very powerful experience for people with psychosis, again, to help them deal with these types of confusing, distressing experiences that they might have. And then, of course, another thing that we would want to bring into treatment, even for people who might be more acutely ill, is figuring out how to develop their mindfulness practices and their mindfulness experiences. But the thing is that you have to do it in a modified way for people with acute psychosis. You have to actually modify the procedures. So there are a few things that are good rules of thumb. One is that you want to make them relatively brief. As little as 1 minute is fine. You do like MBSR training, and you're sitting there intensively meditating for 40 minutes for an hour. That's not really the best way to approach it for somebody who has sort of a more acute, distressed situation that they're in. So keep it brief. Instead of eyes closed, keep eyes open. Do a lot of verbal instruction and prompting so that they don't kind of get lost or preoccupied. But then you can kind of apply that to various different activities. So you can, instead of sort of doing an internal eyes closed meditation, you could still do some attention to the breath with eyes open and sort of being more aware. But what I usually like to do with people with psychosis is really focus more on mindful activities and how they can be mindful while they're doing various activities. And that just kind of makes a lot of intuitive sense from a clinical standpoint, that we're actually not trying to foster the person to be more internal, more in their internal world and engulfed in that. We actually want them to be more outwardly focused and more focused on their environment and more engaged with the world. And so mindful activities that promote engagement in the present moment with the world and what's going on around them can be very helpful for somebody who's experiencing psychosis. So that could be mindful eating, that could be mindful walking. It's as simple as having somebody clap and notice how that feels right after that, what the sound is, listening to music. Even if you have sort of therapeutic animals or access to that, or stuffed animals or something, the tactile sensory experience, using that for mindfulness. So there's great exercises that you can do that maybe aren't sort of your traditional, Buddhist monk, you know what I mean, monastery things that you're going to do, but you're going to do things that are much more real world practical and something you can really do in any place. It can be even on an inpatient unit. This is just sort of a simple little exercise that can be helpful that people can do. The stop process, first stop yourself, then take a few deep breaths, observe what's going on around you in the moment, and then proceed with your committed values and actions and what that might look like in the moment. That again is just reinforcing and helping people to do mindfulness in the moment, in the real world as they're at any point. You know what I mean? They don't have to have a private space to do it. They don't have to have quiet. They don't have to, have those things that are on an inpatient unit that you're not going to have. And they can still be practicing these things. And then, of course, something that is also incredibly important, but I think often missed in these settings, is this focus on helping patients with their values and what's important to them. And so just like that's a central part of ACT in general, it's no less relevant for this population. In fact, it's probably even more relevant. So I think when you're in an environment that maybe is scary, if you're in an environment where you're upset, you're not sure of things, if you're in an environment that's restricted, where some of your liberties are taken away, like it's really important that treatment addresses this kind of question as well. And again, there's lots of ways to build valued activities and things like that. A few things that I find useful. So one you might be familiar with is something called the values bullseye. So this is where sort of you help a person to identify, well, where on that bullseye would I fit my link between the things that I value and then how close I'm getting to where I want to be with that value on the bullseye. And so that's something you can use to track different values from session to session so that you can see, if the person is at that particular X and they want to move forward, then you can think tangibly about, okay, well, what can you do from this session to the next session that would be closer to the mark for you, that would work for you in this particular instance of where you're at right in the here and now. And so I think that can be a really useful thing to help orient people to their values and how well they're aligning with them and what they can be doing to get more in alignment. The other thing is sort of various card sorts. So, often people, again, with psychosis, it might not be a good idea if they're kind of acutely symptomatic to focus so much on sort of a philosophical discussion that's very esoteric or very kind of abstract, and instead to physicalize things more. So using cards that you can give people to look through. Maybe they have a hard time kind of expressing it spontaneously, like what their values are. But if you give them like a card sort or something, you say, look through there, which one of these cards interests you? Which one of these cards speaks to you? I'd love to hear more about it. I'd love to talk and learn more about it. What does this remind you of? Did you ever have a time in your life when that was in that where there was courage, where there was compassion, where there was excitement? What was that like for you? How can we help you to identify ways of getting more of that in your life now moving forward? So I think that can be a really powerful thing to do and really helps to personalize what we're doing. Because again, keep in mind, you're asking people to do things that are very difficult. So there has to be a good reason and willingness to do it. And then finally, I just would kind of focus a little bit on this idea of it's really important that we don't just stay in the counseling session talking to the patient, right? It's about really focusing on how to translate these things to committed action, using cartoons, using little illustrations, there's lots of YouTube videos that you can show patients. So, but basically, like, this is a great illustration because it basically most people resonate with this picture. This is what they feel like. They want to go in a certain direction, and something's in the way, and they feel like, well, I got to go to this other path, even though I don't want to go there. But that's the path I'm going to have to take, right? And really, what we want to understand is, well, how can you adopt a different model where you're bringing along this thing instead of letting it be your obstacle? And I think, in particular, for people with psychosis, these suspicious thoughts or delusional thoughts that they might experience often are getting in the way. And if they can recognize that they're getting in the way, it doesn't matter if they feel like they're true or false. It's also a question of whether or not they're helpful or they get in the way. And I think if they decide that they're still getting in the way, even if they might or might not be true, it's something you can adopt of, well, instead of trying to rid yourself of them before you move forward, how can you bring them along with you? How can you carry them with you? And that's what some of these other processes like mindfulness and acceptance and diffusion can help that person to adopt more of that stance in the moment. And some of you might be familiar with this passengers on the bus metaphor. There's a nice YouTube video that you can show patients that illustrates this. But this kind of metaphor can really help people to kind of bring some of these different elements that I talked about together. So again, we use this for Mary, where we use sort of this metaphor to help her to tie together what it's like to actually implement these things in the real world, right? So this metaphor basically says, you've got these negative thoughts, and they're your unruly passengers, and they're telling you what to do, and they're kind of causing disruption on your bus, but that you still have sort of that control as the driver to go where you want, regardless of what the passengers say, even though, you might hear that they protest. And sometimes you might like the passengers and sometimes you might not, or often the case is there's going to be a mix of ones you like and ones you don't like. But how can you still drive your bus in the way that is going to work for you? So, in terms of sort of how Mary responded, she responded pretty well. I would note that when people have active psychosis and you're doing anything that's sort of committed action, behavioral activation, they're going to experience their symptoms in those situations. So, yeah, if you want to avoid all symptoms, you can have them stay in their room and just wait to get better. But then they're not going to get better often, right? So it is about sort of an exposure model of therapy where, yeah, you're going to come into contact with these things. It's about anticipating that, preparing the patient for it, supporting them, and helping to give them the skills that they can develop to be more effective in those situations, to handle them in a way that's helpful. And so obviously you have to build that up. You can't overwhelm the patient. You have to support them, and you have to do it step by step. But you can't really avoid your way out of those situations. And so Mary did quite well. She was able to recover in terms of discharge. She didn't have subsequent rehospitalizations, at least for a while after that, as far as we know. And some of the things that she started engaging in was she started engaging more in her life after her hospitalization. And I think that's the key, right? She started some volunteer work. She improved some interactions and communications with her family, and she did various leisure activities and things that were meaningful to her. So I think those things all helped to help her stay out of the hospital successfully. So in terms of if you're asking or wondering kind of how this relates to traditional CBT for psychosis, of course there's going to be overlap, as you can tell based on some of the things I talked about. So it's not completely different than traditional CBT, but I do think that there is a real kind of distinction that is important. So traditional CBT really is about using a lot of these cognitive behavioral strategies to try to change directly the patient's beliefs about their psychotic symptoms. Whereas in ACT, we don't take that approach. I'm not saying it's not good to do that. It can be good to do that. But if you can't, or if the patient doesn't want to, or you can't, or they've tried that and it's only gets them so far, what we can also think about doing is changing the patient's relationship to these experiences instead of directly changing the experiences so that they can actually function better regardless of whether those experiences are coming up for them. So I think that's another way to get at this problem that can be slightly different than some of the other treatment that they might have tried before. And that's why it can be helpful. So just to kind of summarize here, again, keep in mind, we don't want to do intensive meditation practices with people with acute psychosis. Instead, we want to modify them to make them safe and effective. And that means focusing more on external attention and focusing more on mindful activities is often helpful. Like I said, we're not saying that ACT is necessarily better than CBT or vice versa. We don't actually know. We don't really have head-to-head comparisons. They might have slightly different processes, but maybe similar outcomes. We don't know. But just keep in mind, there is evidence to support ACT as an efficacious treatment. I think the issue of medication comes up a lot with this population. We take ACT sort of approaches it from a very pragmatic, values-based perspective, right? So it's not about, take your meds or don't take your meds. It's about where does medication fit in to your life, your functioning, your values, and then how do we make that work as best we can with that? So instead of saying, oh, you got to take your medications or kind of pressuring the person. It's really about exploring like where do these fit in? Where do they not fit in? How can we make this work better and more consistently for you? And then finally, the bottom line is that you're doing very similar ACT exercises that you do with other patient populations, but you're actually, just making some relatively slight modifications. You're making them more concrete, you're simplifying them, you're repeating them. You're not just doing them once, you're maybe doing them repeatedly over sessions, and that can be quite effective. Obviously, I just scratched the surface. If you want to learn more, there are several books out there that you can look to learn more and to get more guidance on some of these techniques, both for inpatients and outpatients. And I will stop there. Give us some time to take some questions. So thank you for listening.
Thank you very much, Brandon, for your presentation on psychosis in clinical setting. And uh, for everyone, there's time to write down your questions in the chat. And till then, I will ask one question. Um, do you pay attention to any historic reasons for which people develop psychosis? Does it inform your treatment, or do you focus on like the current presentation? Could you talk a bit about that?
Yeah, that's a great question. I definitely think it's very important. Um, Certainly, the more you know about the person's history, the more that I think you're going to be able to do a better functional analysis because that often can be very key to deciding or selecting which processes to focus on, what type of strategies maybe are going to resonate more with the patient. You don't want to take a very, cookie cutter approach. You want to very personalize these things. Use any of the metaphors that I mentioned or none of them. Make up your own metaphor, or sometimes the patient makes up a metaphor, right? So you do want to personalize it, and that history is important. What I've found is that sometimes because of the brevity of treatment and because of the fast nature of the treatment setting, sometimes I want to get into more of the history, but I just can't for practical reasons. So I focus more on the immediate before the hospitalization. But I feel like exploring the history really helps you to capitalize and highlight their experience to know like where avoidance isn't working. And I think the more you can kind of understand that, the more you can help the person to think about, well, what would be a different way to approach this next time or now going forward? If that didn't work or if that didn't really get you where you want to be at, how could we think out of the box and find something else? So if you know that history, you can really, I think, better tailor that. So
Thank you. And there's a question from Dagmara. How do you address the risk of experiential avoidance in clinical teams working with psychosis, where avoidance of distressing content is often reinforced?
yes, that's a great question. So I think one of the things that, I'm glad you asked that is because you're not just treating the patient in these settings, right? Like the setting is part of the issue, right? Like I said, people are in a restricted setting. They don't have the freedom that they usually have. And they also are getting exposed to other messages, right? And some of those messages are going to be maybe very inconsistent with what we're talking about here today. And so that's why, again, taking this very pragmatic and values approach can be helpful to. So first of all, don't ignore those things. Bring them out into the open. Talk to the patient about them. Talk to the team about it. Share with them. Hopefully, you have, if you're working in these settings, you've developed enough of a collegial sort of interactions that people will at least, even if they don't kind of approach it in the way that you would, they kind of respect that you know something about this and have something to say here. And then what you want to do is try to figure out, again, from a practical standpoint, how can these things not be in such conflict, but we can find a way to make them work for the patient, and how can that patient find a way to make them work within their values in a way that is values consistent. That does not mean that that's always going to end up that way, but I think often you can navigate a lot of these things more if you really just get explicit about, yeah, like there's this particular way you're hearing this, I'm talking about this. How would we make these things work in practice for you today? Right. So it's really about just honing in on not worrying about the wide world and resolving all the conflicts in the field or trying to fix all the person's problems at once. It's really just about, okay, well, what does this mean today? How would you navigate that? And sometimes it does mean advocating for the patient in a treatment team meeting, in terms of working with your colleagues to really help to educate them. Oh, okay, we're taking a different approach. We're trying to do it a little bit more this way. This has been helpful. It's not that different to the way you kind of get into exposure therapy, trying to do exposure therapy with anxiety and how that can conflict with other messages. So I kind of use analogies even with my colleagues, and I kind of say, well, it's kind of like this. It's kind of like if we were doing exposure, we would expect the patient with OCD to have a little bit more symptoms at first before those went down. And so maybe that's what we're seeing. So if you can kind of explain that and work with people and then find a way to help the patient to understand that those things have to be navigated too, I think often you can find something that's a way to actually make it work in that case. Hopefully that kind of addressed some of the
Yeah,
question.
thank you so much.
Did you have anything to share, like a particular example or something that would be helpful?
Well, not really. It's I think very common issues in Poland that we are very into traditional psychiatric terms. We didn't pass through positive psychology, no, through the communism. So we have quite a totalitarian system in the psychiatric hospitals. So it's very difficult to work with, people that they are working there like a 40, 50 years and they only think the right way of treating psychosis, which means mostly using a lot of sedative medication. No, it's like that's not treatable. Okay, we are closing the subject. That's it.
Yeah, I'm glad you acknowledge that because that is certainly, and it's certainly the case, I think, everywhere to a degree, and I'm sure some places more, it's even worse than others. Um, it sometimes is the case that, if you can, you do need to advocate for working with the prescriber if you have that kind of relationship with them to talk about often decreasing the dose of medication is the right thing to do in a lot of these cases clinically. Just from a evidence-based standpoint, we know that over sedation is going to lead to more impairment and is not going to improve functioning. It's not going to make them better. There's sort of a sort of what the medication can do, and then there's everything else that has to be done. So I think if you can figure out a way to work to maximize the benefit of the medication, but then maximize the benefit of other treatments, like if that's a model that can work. But I agree, it just depends on the person. It depends on the setting can dictate a lot of what they're used to or what they're not. So it can be a challenge.
Yeah, thank you so much.
Yeah, I think we reached a full hour. At least we'll be
Wow,
reaching it
goes
very
fast.
soon. Yes. Indeed. So, thank you very much, Brandon, for this lecture, and for everyone who is attending, who's part of ACBS Poland or from abroad. We will also be delivering a lecture next week with Eric Morris, also on Friday at 10 a.m. So, thank you very much, and for everyone else. See you soon, hopefully.
It was my pleasure. Thank you so much. Have a great day, everybody.